Welcome to the talk about MRI in rectal cancer pre and post treatment evaluation. I have no disclosure. First, we will discuss some background about MR protocol and relevant MR anatomy, and then go over the role of MR in pre-treatment staging and evaluation of response after chemoradiation. Why we use MRI in evaluation of rectal cancer? That's because MR offers good soft tissue contrast resolution and therefore provides precise anatomic detail that is good for radiation and surgical planning. From a large well-known multi-center trial, the Mercury trial, it showed great correlation with histopathology and excellent ability to determine prognosis and stratify patients to treatment arms. The potential benefits of rectal MRI are strictly dependent on obtaining good quality images. The most important sequence is fast spin echo T2 without fat suppression, small field of view about 20 to 24 cm, and the section thickness less than 3 mm. And because this high resolution protocol, we obtain this protocol in three planes: sagittal plane, axial oblique, perpendicular to the tumor. This is used for T staging, and the coronal oblique, which is parallel to the anal canal, to show the relationship between tumor and anosphincteric complex. Here is an example to show how to obtain optimal axial oblique plane. First, we obtain sagittal T2 to localize the tumor. In this case, the tumor is at posterior wall of mid-rectum, so the optimal axial oblique plane should be perpendicular to the long axis of the tumor like this, and then we get the good axial oblique plane that is important for T staging that I will discuss later. With the high resolution MRI, we can see bowel wall layer clearly in axial plane. This patient has rectal cancer at the anterior wall. When we zoom in this area, you can see that the tumor at anterior wall shows intermediate or great signal intensity. There is no cancer at the posterior wall, but the wall is edema with good bowel layer separation. This is the correlation between MRI and histopathology in the same patient. The innermost high signal intensity is mucosa, and the next low T2 signal intensity is muscularis propria. The submucosa hits high signal intensity and the thickest part of the bowel wall, and the outermost low signal intensity is muscularis propria. The next important structure we can see on axial MR is mesorectal fascia, which is the low signal intensity lines enveloping the perirectal fat and rectum. Mesorectal fascia represents the surgical excision plane or potential circumferential resection margin for TME. In sagittal plane, we can measure the distance of the inferior part of the tumor from the anal verge and see the relationship between the tumor and adjacent organs, which are prostate, seminal vesicle, urinary bladder, and thin low signal intensity line of the peritoneal resection. In the coronal plane, which is an important plane for lower rectal tumor staging, and we can see the relationship between the tumor and the anal canal sphincter and pelvic floor muscles. Here's the internal sphincter. This is the external sphincter. This levator ani muscles. These structures are low signal intensity because of fibrous soft tissue component, and there is thin fat plane locating between the internal sphincter and external sphincter. Moving on to pre-treatment staging. The objective of pre-treatment staging is to stratify patients to treatment arms, which are neoadjuvant chemoradiation or surgery alone, and identify poor prognostic factors. In pretreatment staging, we evaluate location of the tumor and morphology, including mucinous tumor, T-staging, anal complex involvement, mesorectal fascia or circumferential resection margin status, extramural vascular invasion or EMVI, nodal staging, including lymph nodes outside mesorectal fascia. The green highlights are poor prognostic factors, which are mucinous tumor, depth of tumor invasion, CRM, EMVI, and nodal staging. Traditionally, the rectum has been divided into three segments. If the lower border of tumor lies within 5 cm from the anal which is low rectal tumor. If the lower border of the tumor is between 5 to 10 cm from the anal which we call it mid-rectal tumor. For the upper rectal tumor, the lower border is higher than 10 cm from anal which. Mucinous tumor can be appreciated on MRI. The mucin component is high signal intensity on T2. Here you see a very large rectal tumor involving from lower to upper rectum with very high signal intensity component that represents mucin component. This patient also has right obturator nodal metastasis containing high signal intensity, which is mucin component. T-staging is the relevance of the tumor to the rectal wall. T1 tumor is confined to the mucosa and submucosa. T2 tumor invades the muscular layer of the wall, while T3 tumor extends beyond the muscular layer into the mesorectal fat and is subdivided into A, B, C, and D. T4A invades peritoneal reflection and T4B invades other organs. MRI cannot differentiate between T1 and T2 tumor. Endoscopic ultrasound is used for distinction between T1 and T2 tumor because it can see mucosal and submucosal layer more clearly. This is an example of T2 tumor that invades but does not penetrate muscularis propria, as you can still see the intact low signal intensity line of muscularis propria without tumor breaking through. Here's an example of T3A tumor extending beyond the muscularis propria less than 1 mm. In this case, there is nodular extension of tumor beyond the expected muscularis propria plane about 3 mm, compatible with T3B. Here, the tumor invades mesorectal fat about 10 mm from the expected plane of muscularis propria, so it is T3C. This is T3D tumor extend more than 15 mm beyond muscularis propria. This is a large ulcerative mass invading mesorectal fascia and peritoneal reflection compatible with T4A. T4B tumor invades adjacent structure which are organs anterior to the rectum, including vagina, bladder, prostate, and seminal vesicles, and pelvic floor muscles. In this case, the tumor invades peripheral zone of the prostate and left levator A9 muscle, compatible with T4B. Rectal cancer often produces desmoplastic reactions, so when we see speculation in mesorectal fat, sometimes it's difficult to differentiate between T3 tumor and T2 tumor with desmoplastic reaction. In theory, extramural desmoplastic reaction should be seen as thin fine low signal intensity line in the mesorectal fat like this. On the other hand, in T3 tumor, there are thick nodular bands with intermediate signal intensity in the mesorectal fat in continuity with intramural portion of the tumor. However, practically, the differentiation between T2 tumor with desmoplastic reaction and early T3 tumor are sometimes very difficult. For example, in this case, there is a tumor at left lateral wall of mid-rectum with fine speculation in the adjacent mesorectal fat, so I read as T2 tumor with desmoplastic reaction, but the pathology came out T3 tumor. Since T2 and T3A tumor has no different prognosis, in some guidelines, pattern of speculation of perirectal fat could be reported as T2 or early T3. Moving on to the evaluation of anal complex, the lower rectal tumor are within 5 cm from the anal wall. They have special challenging as they are associated with higher rate of positive resection margin, higher local recurrence, and poorer survival. MR coronal image is the key image that helps define the tumor location relative to the sphincter complex. There's a proposed specific T-staging for low rectal tumor based on coronal and axial T2. In stage 1, tumors confined to the internal sphincter. Stage 2, tumor involves the whole layer of internal sphincter but does not extend into the intersphincteric fat plane. Stage 3, tumor involves intersphincteric fat plane. And stage 4, tumor invades external sphincter. This is an example of stage 4 tumor that involves bilateral external sphincter and left levator ani muscle. We also evaluate mesorectal fascia or circumferential resection margin status. Potentially positive margin is defined as tumor lying within 1 mm of the mesorectal fascia. This applies to suspicious lymph node, the main tumor, EMVI, and the tumor deposit. In this case, you can see the thin, low signal intensity line of the mesorectal fascia and a large lymph node with heterogeneous signal intensity and irregular contour that is likely nodal metastasis abutting the mesorectal fascia. So this is potentially positive margin. Let's move on to nodal staging. Nodal staging is difficult. If you use a lead size or the short axis diameter, you will miss several nodes that are metastatic nodes. That study showing that 15% of the lymph nodes smaller than 5 mm are metastasis. Therefore, morphologic criteria has been added, which are irregular borders, heterogeneous signal intensity, and round shape. The study showing that using these two criteria gives high sensitivity as 85% and high specificity as 95%. For example, this patient has rectal cancer and multiple mesorectal lymph nodes. The largest one is about 1.1 cm in short axis with round shape, smooth contour, and homogeneous signal intensity. This group of small nodes is about 5 to 7 mm with heterogeneous signal intensity and irregular contour. In histopathology, these nodes turn out to be benign lymph nodes, and these are metastatic lymph nodes. These are criteria for malignant nodes proposed by European Society of GI and Abdominal Radiology or ESGAR, including all the nodes with short axis equal or more than 9 mm. The node with short axis 5 to 8 mm need at least 2 suspicious morphology, and the node with less than 5 mm in short axis need 3 suspicious morphology, and all the mucinous lymph nodes are the nodal metastasis. Extramural vascular invasion or EMVI that occurs in up to half of the cases of colorectal cancer. It is one of the poor prognostic factors. Generally, EMVR is associated with at least T3 tumor. The MRI findings are presence of tumor signal intensity within the vessel, and that vessels are expanded with or without disruption of the vessel border. EMVI can be contiguous with tumor or not. This is the example of the normal vessel adjacent to the tumor. In this case, tumor is T3C, and you can see that the vessel abutting the tumor is enlarged with the tumor signal intensity inside. This is consistent with EMVI. This is an example of extensive EMVI. These vessels are enlarged with nodular and irregular contour and tumor signal intensity inside. This is an example of discontinuous EMVI. Here you see the tumor at mid-rectum and EMVI in the right side mesorectum without connection between tumor and the EMVI. How good is MRI for pretreatment staging? From the meta-analysis, the study showed that MR has high specificity in evaluation of adjacent organ invasion and CRM involvement, with the specificity of 94 and 96% and moderate specificity for the lymph node involvement and polyrectal fat invasion. Moving on to the last content, the evaluation of response after chemoradiation. After chemoradiation, we evaluate pretty much similar to the pretreatment staging. T-staging, tumor response, anal complex, involvement, circumferential resection margin, nodal staging including the lymph nodes outside mesorectal fascia and EMVI. After chemoradiation, most of tumors develop fibrosis, which appear low signal intensity on T2 with decreased size and downstaging, and some tumors develop mucin, which is high signal intensity on T2. For example, in this case, the tumor appears intermediate or great signal intensity on T2 in pretreatment. After chemoradiation, the tumor does decrease size, with some residual tumor showing great signal intensity on T2 and development of low signal intensity of fibrosis and high signal intensity of mucin. In addition to T-staging MR tumor regression grade has been proposed. It is derived from histopathologic grading, and the evaluation is based on the component we see on MRI: fibrosis, low signal on T2, mucin, high signal on T2, and residual tumor, intermediate signal on T2. There are 5 grading. Grade 1, complete response, meaning no evidence of any abnormality on MRI, which I never seen or assigned this grade. Grade 2 is good response, with dense fibrosis more than 75% and no or minimal residual tumor. Grade 3, moderate response, showing more than 50% fibrosis with small residual tumor. Grade 4 is slight response, with small area of fibrosis and mostly residual tumor, and grade 5 is no response. For example, in this case, in pretreatment staging, there is a polypoid mass at anterior wall of mid-rectum. On axial plane, you can see that there's extension of tumor beyond muscular dyspropria about 6 mm, compatible with T3C tumor. After chemoradiation, the tumor has become mostly dense fibrosis with barely seen residual tumor. Again, on axial plane, you can see that the tumor has become mostly dense fibrosis without viable residual tumors seen. This is compatible with tumor regression grade 2 good response. The pathology report of this case shows that the tumor size is about 2 by 1.5 by 0.4 cm without residual viable tumor. This is consistent with complete pathologic response. Another example, in this patient, the tumor is at mid-rectum. On axial plane, you can see that the tumor is at left lateral wall of mid-rectum, with or without minimal invasion into mesorectal fat. This is consistent with T2 or T3A tumor. After chemoradiation, the tumor have become mostly fibrosis without residual tumor seen, compatible with GRG2 good response. The patient denied surgery and agreed to be close follow-up with endoscopy and MRI. He's doing very well so far. The recent MRI showed small fibrosis with generalized submucosal edema related to post-radiation change, but no evidence of recurrent tumor. Similarly, there is no evidence of recurrent tumor seen on endoscopy. The accuracy of T-staging after chemoradiation is less than pre-treatment evaluation. It is about 50% compared to 80% at staging. This is because the difficulty in distinguishing post-radiation inflammation and edema mucosa from the small foci of residual tumor, and the radiologists tend to overstage. Downstaging of nodal metastasis also occurs from 40% to 20% after chemoradiation. After chemoradiation, both benign and malignant nodes will have speculated border. The differentiate between benign and malignant nodes just from looking at post-treatment imaging is not possible, so we should compare pre- and post-treatment MRI staging together. Similarly to pre-treatment, we have to look carefully for the lymph node outside mesorectal fascia. For example, these are post-chemoradiation MRI of two patients. Both of them have irregular border lymph node that could be post-chemoradiation change. We cannot really tell which one is benign and which one is malignant. However, when we look at pre-treatment MRI, we can tell that the first one is malignant lymph node because of irregular border and heterogeneous signal intensity, and the second one is benign lymph node because of the homogeneous signal intensity and smooth contour. A study has proposed predictors of negative node status after chemoradiation, which are node-restricted diffusion on diffusion-weighted imaging MRI, decrease in size in at least 70%, and size less than 2.5 mm in the short axis diameter. The last case that I like to show, this patient has tumor at posterior aspect of mid-rectum. On axial plane, you can see that the tumor invades mesorectal fat more than 50 mm beyond the muscularis propria. This is 3TD tumor. Also, there is high signal intensity component in the tumor representing mucin and EMVI abutting the tumor at the left lateral aspect. So this is T3D mucinous tumor with EMVI. Patient also has nodal metastasis containing mucin component around the superior hemorrhoidal vessel. After chemoradiation, the tumor slightly decreased size with development of some fibrosis showing low T2 signal intensity. However, you can see some residual viable tumor showing intermediate T2 signal intensity. So this is tumor regression grade 3 moderate response. Again, on axial plane, you see some residual viable tumor showing T2 intermediate signal intensity and EMVI at the left posterolateral aspect of the tumor. The nodal metastasis along superior hemorrhoidal vein is no significant change in terms of size and appearance. The pathology report of this patient shows the tumor size is about 3 by 1.5 by 1.5 centimeter with residual viable tumor moderately differentiated adenocarcinoma. So the pathological state is YPT3N1A. and there's a viable tumor more than 50% and positive for mucin and lymphovascular invasion. He underwent CT at 3 months after surgery. The CT at the pelvic cavity shows post-APR with pre-sacral soft tissue thickening, which is slightly more prominent with nodular thickening on the right side. Although this could be post-operative change, the recurrent tumor is also possible. Here is the nodular thickening at the right side of pre-sacral soft tissue. And the patient developed multiple liver metastases. His CT at 7 months after surgery showed more prominence of enhancing nodule at the pre-sacral region, likely representing local recurrence and increased size of multiple liver metastases. This is an example of the case with multiple poor prognostic factors, including high T staging, mucinous tumor, positive EMVI, and nodal metastasis seen on MRI, and moderate treatment response after chemoradiation, which are compatible with his pathology findings. So he developed early local recurrence and distant metastasis. MRI helps stratify patients to treatment arm and identify the prognostic factors. However, the potential benefits of rectal MRI really depends on the good quality images, what we call the high resolution protocol. The size alone is not reliable in pre-treatment nodal staging, and the overall accuracy of post-treatment evaluation is less than pre-treatment staging. Thank you.